welcome back to my channel. Today we are going to be talking about evaluation and management coding, also known as E&M coding. This video is an introduction, the tip of the iceberg. So if you're a student, make sure to stick around. I hope that after today, this video gives you a better understanding of what evaluation and management coding is and makes you feel more confident in yourself. Intro to E&M coding. Remember, this is an introduction to evaluation and management coding. This is not everything you need to know about E&M. Anytime a patient receives an evaluation by a provider or is seen for management of a condition, an E&M code will be reported. These are used in all healthcare specialties and used by all types of healthcare providers. Where are E&M codes used? Inpatient, outpatient, telemedicine, and more. They are used to report evaluation and management of a patient across all healthcare settings. An example would be an outpatient office, inpatient hospital, consultations in both outpatient and inpatient settings, emergency departments, nursing facilities, home visits, telemedicine appointments, etc. When are E&M codes used? When the patient receives evaluation by a provider or management for a condition. So an example of the very first one, when a patient receives evaluation by a provider, would be when a patient is seen for a physical exam and counseling. Management of a condition would be when the patient goes in for a medication refill request. 3 factors of E&M coding. What is the type of service? What is the patient status? And what is the place of service? Let's start with the very first one. What is the type of service? This refers to the kind of E&M encounter. So for example, was it an office visit, a consultation, hospital discharge, telemedicine? The second one, what is the patient status? There are 4 types of patient status: new patient, established patient, inpatient, and hospitalization. To determine which one it would be, there is a decision tree for new versus established in the front of the E&M coding section of your CPT code book. You also need to look over your coding guidelines at the beginning of the E&M section to get more information on patient status. And the third one, the place of service. The place of service is where the service was delivered. So the outpatient setting, outpatient office, skilled nursing facility, was it in the hospital? Here is an example. A new patient presents to the office of a psychiatrist in the town where she has just moved. She had been under treatment for depression where she lived previously, and her new psychiatrist performs a medication history, side effect history, and a mental status examination. He then prescribes an antidepressant to the patient. The service would be office visit, the status would be new patient, and the place of service would be office. 3 factors of E&M codes continued. Before addressing the 3 key components that make up E&M codes, as a coder, you must determine the type of E&M service by defining the 3 factors, which are type of service, patient status, and place of service. Practice time. Oh yeah. Initial hospital inpatient service provided to a patient with schizophrenia suffering from panic attack. The type of service would be initial care. The patient status would be inpatient. And we gain all of that information from the scenario itself. The place of service is hospital. The E&M code, we're going to do a range for this one. It would be 99221 to 99223. If you open your CPT code book to the E&M section, you will see there are many different subheadings within that section. One of those is initial hospital care. And in that subheading, there is the category new or established, and then you would find that code range 99221 to 99223. The place of service code is 21. The place of service codes for professional claims is at the front of your CPT code book, and you would select 21 for inpatient hospital, and that would go on your claim form. 3 key components. The provider typically asks pointed questions to get more information from the patient and help determine what to focus on during the physical exam. Now remember, the subjective information is what the patient tells the provider, and there are 4 elements of a history. There's the chief complaint, history of present illness, review of systems, and then the past family and social history. 3 key components continued. This will be the examination. This is objective information from the physical exam itself. Now, the physician is going to be doing an exam of body areas or organ systems. Here's an example. A provider seeing a patient for anxiety may find during the physical exam that the patient has been experiencing heart palpitations. That provider would then review the cardiovascular system as well as neurological and psychiatric system. 3 key components. The third one is medical decision making, also known as MDM. The MDM for a patient with anxiety includes the number of possible diagnoses, such as anxiety, heart palpitations, or any other possible complications, any labs, imaging services, or other healthcare services that should be performed or reviewed, and the risk of complication if the anxiety and heart palpitations are left untreated. The 3 key components to an E&M service directly correspond to a common format for health record documentation, and that is known as SOAP notes, or the SOAP note. SOAP stands for Subjective, Objective, Assessment, and Plan. This is typically used for a problem-oriented visit, and you can see the arrows that I have on the screen. Subjective is going to be your history, objective corresponds to the exam, and then the assessment and plan is going to fall into that MDM category. Levels. There are 4 levels of each of the 3 key components. So history, exam, and MDM. To select the correct E&M code, the coder must determine the level of each of these 3 key components and then locate that corresponding E&M code. For example, if a provider performs a comprehensive examination of all body areas and organ systems on a patient, it is considered a high level of examination component, which falls in the comprehensive category. On the other hand, if a provider performs only a limited examination of one body area, it would be a low level of the examination component, which would fall into the problem-focused category. Levels. This is history. If a provider completed a very low level of history, then the lowest level of this key component would be used to select the level of history for this service, and that would fall under the problem-focused range. Examination. If a provider completed a very high level of examination, which would be a complete examination of multiple body areas and organ systems, then the highest level of this key component would be used to select the level of examination for that service, and that would fall under the comprehensive range or level. Levels again. This time we're talking about medical decision making. If a patient with a simple problem, such as a small abrasion on their head, was seen by the provider who only needed to perform a very low level of MDM or medical decision making to treat that patient, the lowest level of this key component would be used to select the MDM level for this service, and that would be straightforward. The dreaded contributing factors. When I'm auditing, sometimes it's like trying to find a needle in a haystack because this stuff has to be documented, and sometimes it's so poorly documented, it's very difficult to find. Contributing factors include counseling, coordination of care, and nature of presenting problem. The levels of the 3 key components are not always necessary for code selection. For example, when the 3 key components have not been completed, for some ungodly reason, I don't know, you may use other contributing factors such as counseling, coordination of care, or nature of the presenting problem. In order to use time, more than 50% of the face-to-face time spent with the patient or floor or unit time must have been spent on counseling or coordination of care. The amount of time must be documented, and it must be clearly documented. The extent of counseling or coordination of care must be documented. So the doctor has to put all of that in the medical record that he spent more than 50% of time with the patient or on counseling or coordination of care. And it has to be clearly legible. You should be able to pull that right out of there. E&M code selection. Determine the level of E&M code based on the required key components. Some codes will require 2 key components and some will require 3. If 2 out of 3 components are detailed and 1 out of 3 is high, then you cannot select a code higher than the detailed. Practice time. A 42-year-old patient is brought into the office by his family for evaluation of alcohol abuse with paranoid delusions. A comprehensive history and examination were performed. MDM was high complexity. Patient was prescribed a neuroleptic and referred to an Alcoholics Anonymous program. For this one, you'll see that this was a new patient. It was in the office setting. It was for an evaluation. The history and examination were comprehensive, meaning they were the highest level possible. And then the MDM was also of high complexity, which is the highest level possible. So in your CPT code book, you would then turn to the office or other outpatient services section in the evaluation management coding section, and you would look for the highest code, which would be 99205. That contains a comprehensive history, a comprehensive examination, and medical decision-making of high complexity. All 3 of the key components must be met for this code. Then you would look for the diagnosis code in the ICD-10 CM code book. And the diagnosis for this patient was alcohol abuse with paranoid delusions. And that wraps up E&M coding. So if you have any questions over E&M coding, or you would like to see another video, hit subscribe, give me a thumbs up, and let me know in the comments.